Ventilator-associated pneumonia, VAP, is a significant concern in mechanically ventilated patients and poses both clinical and economic challenges. In this comprehensive script, we will delve into the various aspects of VAP, from its pathogenesis and microbiology to diagnostic criteria, management, prevention strategies, and emerging therapeutic approaches. Additionally, we will explore complications, prognostic factors, considerations for special populations, and the importance of surveillance programs. By the end of this script, you will have a deep understanding of VAP and be equipped with the knowledge necessary to effectively manage and prevent this condition. Let's begin our journey into the world of ventilator-associated pneumonia. Mechanical ventilation alters the normal defense mechanisms of the respiratory system, making patients susceptible to bacterial colonization and subsequent development of VAP. The endotracheal tube acts as a conduit for microorganisms from the oropharynx and environment to reach the lower respiratory tract. Impaired cough reflex and decreased clearance of secretions further contribute to the proliferation of bacteria. Additionally, biofilm formation on the endotracheal tube further promotes bacterial adhesion and colonization. The most frequently isolated bacteria in VAP are gram-negative organisms, such as Pseudomonas aeruginosa, Klebsiella pneumoniae, and Escherichia coli. However, gram-positive pathogens like Staphylococcus aureus, including methicillin-resistant strains, MRSA, are also commonly implicated. Polymicrobial infections, involving both gram-positive and gram-negative bacteria, are not uncommon in VAP. Diagnosing VAP is challenging due to its nonspecific clinical presentation and the presence of other pulmonary complications in mechanically ventilated patients. Clinical criteria, including the presence of fever, leukocytosis, purulent respiratory secretions, and worsening gas exchange, are often used as a starting point. However, radiologic findings, such as new or progressive infiltrates on chest X-ray or computed tomography, CT, scan, are often necessary to confirm the diagnosis. Additionally, microbiologic criteria, obtained through quantitative cultures of respiratory specimens, provide further evidence of bacterial infection. The cornerstone of VAP management is prompt initiation of appropriate empiric antimicrobial therapy, guided by local resistance patterns and individual patient factors. Antimicrobial agents should be selected to cover both gram-negative and gram-positive bacteria, taking into account the risk of multi-drug-resistant organisms. The escalation of therapy once culture results are available is recommended to minimize the development of antimicrobial resistance. Adjunctive treatments, such as bronchial hygiene maneuvers and lung protective ventilation strategies, also play a vital role in optimizing patient outcomes. Ventilator bundle strategies, consisting of evidence-based interventions, are crucial in preventing VAP. These include elevation of the head of the bed, daily sedation interruption and assessment of readiness for extubation, peptic ulcer disease prophylaxis, deep vein thrombosis prophylaxis, and daily oral care with chlorhexidine. Implementing these bundles reduces the incidence of VAP and improves patient outcomes. Preventing antibiotic resistance is a global challenge, and VAP is no exception. Antibiotic stewardship programs aim to optimize antimicrobial use, ensuring appropriate therapy while minimizing the development of resistance. Infection control measures, including hand hygiene, isolation precautions, and appropriate cleaning and disinfection of equipment, are paramount in preventing the spread of multi-drug-resistant organisms and reducing the burden of VAP. Several variables influence the prognosis of VAP. These include the severity of illness at the time of diagnosis, the presence of comorbidities, the adequacy of initial antimicrobial therapy, the development of complications, and the duration of mechanical ventilation. Identifying these prognostic factors helps guide clinical decision-making and assists in risk stratification. VAP is associated with various complications that can significantly impact patient outcomes. These include ventilator-associated lung injury, sepsis, development of multi-drug-resistant organisms, acute respiratory distress syndrome, ARDS, and prolonged mechanical ventilation. Early recognition and prompt management of these complications are essential in reducing morbidity and mortality in VAP patients. Ongoing research and clinical trials have identified several promising therapeutic approaches for VAP. These include the use of novel antimicrobial agents, such as antimicrobial peptides, immunomodulatory therapies, and the potential role of bacteriophage therapy in targeting multi-drug-resistant pathogens. Additionally, adjunctive treatments, such as probiotics, nebulized antibiotics, and immunoglobulins, show potential benefits in improving outcomes in VAP patients. Ventilator-associated tracheobronchitis, VAT, is a distinct entity from VAP, characterized by the presence of lower respiratory tract infection without parenchymal involvement. It is often diagnosed based on clinical criteria, such as new or worsening cough, increased sputum production, and purulent tracheal secretions. Differentiating VAT from VAP is crucial as the therapeutic approach differs. While antimicrobial therapy is usually reserved for VAP, VAT can be managed with conservative measures and avoidance of unnecessary antibiotics. Certain patient populations, such as immunocompromised individuals, those with cystic fibrosis, or patients receiving extracorporeal membrane oxygenation, ECMO, present unique challenges in the diagnosis and management of VAP. Tailored approaches, including the consideration of atypical pathogens, antimicrobial resistance patterns, and avoidance of potential drug-drug interactions, are crucial to optimize outcomes in these special populations. Surveillance programs play a vital role in monitoring the incidence, etiology, and outcomes of VAP. Accurate and timely data collection allows for the identification of potential areas for quality improvement. Implementing strategies such as regular feedback to healthcare providers, promoting guideline adherence, and fostering a culture of patient safety and infection control contribute to the overall reduction in VAP rates and improvement in patient care outcomes. In conclusion, ventilator-associated pneumonia, VAP, is a complicated condition requiring a comprehensive understanding. By implementing evidence-based practices and surveillance programs, we can reduce VAP burden and improve patient outcomes. Continuous education and research are necessary to combat this challenging infection.